Good morning, Ananda. Myself Sakthivel from Medicine. On behalf of Medicine One, I am presenting as a burnout. So, in history, a 65-year-old Mr. X from Kerala presented with complaints of fever for 1 month, which was high grade, as documented as 102, with intermittent fever was more on evening with chills, and cough for 1 month, which was mostly dry with occasional breathlessness, as MMRC grade was 1. And significant unintermittent weight loss was there, which was 10 kg weight loss in the last 4 months, with associated with loss of appetite. And he had history of travel to Canada, which was 4 months back, and in the house he had exposure to cats also. There is no history specific to GI symptoms or history suggestive of any CNS involvements or history suggestive of musculoskeletal involvement like joint involvement, early morning stiffness like. So on past history, he was a known case of diabetes for last 30 years, which was initially on OHA. Later, he was shifted to insulin in due to uncontrolled diabetes. For that above complaints, he was admitted outside hospital for 1 month, extensively evaluated, but cause nothing was found. So he came here for further management. So on examination, vitals was stable, pulse rate of 98 per minute, regular, all peripheral pulse were palpable, respiratory rate of 12 with blood pressure of 120/70. He was afebrile at the time of admission. There is no pale rectal cyanosis clubbing or no generalized lymphadenopathy also. On systemic examination, all system was normal. So our probable differential we considered here was a classical pyrexia of unknown origin, because he was admitted on the outside, was evaluated, and no cause was found, but presented with fever 1 month. So we consider as a classical pyrexia of unknown origin. So the initial differential we consider was infection mainly due to the uncontrolled diabetes. Initially we suspected because of 30 years. So human immunodeficiency virus, tuberculosis, histoplasmosis, amyloidosis, brucella, and infective endocarditis. And disseminated malignancies, lymphoma, leukemia, or solid or malignancies like renal cell carcinoma or hepatocellular carcinoma associated with fever, or endocrine causes, hyperthyroidism, and autoimmune causes less likely. He doesn't have any other except weight loss, no other symptoms, but we'll at the last we kept it also. So sarcoidosis, SLER, connective tissue disorders. So further our initial workup. So initial evaluation, hemoglobin total count platelets was within normal limits. LFT and renal function also was normal. In urine routine, it showed only glucose was 3+, with BBS was negative, and his HbA1c showed 8.3. With uncontrolled diabetes, so we suspected infection, so we sent 3 blood cultures. 3 blood cultures all came as negative. So we sent to inflammatory markers. ESR CRP was elevated. So we did thyroid. So it was 0.04. It was low. And ANAC3 C4 was negative. So for that TSS was low, we sent T4 and FTC. Only the FTC was mildly elevated, 2.14. So we sent antibody workup. So TSH receptor was negative. Only the thyroid antibodies, it showed anti-thyroglobulin was positive. It was 387. So further we did ultrasound neck, but patient wise there is no history of patient have any difficulty in swallowing or neck pain. There is no nothing. So we did ultrasound. In the ultrasound, it showed the left thyroid nodule and feature suggestive of thyroiditis with the thyroid score was 4. So we went for biopsy, ultrasound guided biopsy. Ultrasound biopsy initially showed suggestive of lymphocytic thyroiditis. So our final diagnosis for this patient was autoimmune thyroiditis with thyrotoxicosis, hashitoxicosis, and left thyroid 4 thyroid nodule and diabetes mellitus type. So I look to talk about autoimmune thyroiditis spectrum, autoimmune thyroid antibodies, and malignancy associated after autoimmune thyroiditis. So autoimmune thyroid disease is a organ-specific autoimmune diseases. Mostly it was associated with female. 15% of female was more involved than compared to male. It was less likely, only 5% maximum. So autoimmune thyroid spectrum involve only 2 spectrum. One is hypothyroidism and hyperthyroidism. In the hypothyroidism, we have Hashimoto thyroiditis. In the hyperthyroidism, it is a grave disease. In between, we have some variants of Hashimoto. That is a painless thyroiditis, postpartum thyroiditis, or subacute thyroiditis. So the main basic pathogenesis was due to the autoimmune. Mainly, it's involved both T cell and B cell involvement. The T cells was mostly involved in the Hashimoto, but B cells were mostly involved in the grave disease. Due to the T cell involvement mainly due to the CTL4, cytotoxic T lymphocyte antigen, and the B cell involvement likely due to the CD40. The CD40 was expressed both in the B cell and the thyroglobulin also. So the pathogenesis mainly was multifactorial. Initially, the predisposing factors like genetic was CTL4 and CD40. Then the patient having the trigger factors, smoking, infection, excessive iodine intake, or radiations are. So the excessive iodine intake mostly associated with the painless thyroiditis, radiations also subacute thyroiditis. And it goes to formation of the autoantibodies will cause the autoimmune thyroiditis. So antibodies mostly associated with autoimmune thyroiditis are thyroid peroxidase antibodies and thyroglobulin antibodies. The both mostly associated with Hashimoto, and thyroid receptor antibodies mostly associated with Graves' disease. So mainly the autoimmune thyroiditis panel in the Hashimoto thyroiditis. So both Hashimoto, painless thyroiditis, and others have to typical 3%. So initially transient hyperthyroidism phase, then they will evolve into the hypothyroidism phase. But in other case, like painless thyroiditis and postpartum thyroiditis and subacute thyroiditis, they will present as 3 phase. Initial transient thyrotoxic phase, then they will enter into the hypothyroid, then they will into the euthyroid state. But in the Hashimoto, the mostly the transient thyrotoxic phase, which was mostly patient will present as a asymptomatic. So it will be missed, and it is also shorter duration compared to others. It only 1 month. But in other patients, the thyrotoxic was a patient maximum present to 3 to 6 months. So patient have the clinical symptoms in the other cases. But in the Hashimoto thyroiditis, we don't expect any clinical symptoms except some rare cases. And in the Hashimoto thyroiditis, the histopathological features mainly was the diffuse lymphocytic infiltrate with the lymphoid germinal centers and erythral cells. And patient entered into the last stage was hypothyroidism. So he might require lifelong thyroid replacement therapy. But in other cases, mainly due to the lymphocyte inflammation, in the painless thyroiditis, the pathogenesis mainly due to the already patient having genetic susceptibility to the cytokines and inflammatory markers, and whoever increased exposure to the iodine intake also will develop in the painless thyroiditis. The patients mostly was asymptomatic. When they present mainly as a triple phase only, we can get one is hyperthyroidism or hypothyroidism. They will recover to euthyroid phase, mainly due to the hyperthyroidism, mainly due to the acute inflammatory phase that due to the thyroglobulin destruction. So much of thyroid release, that's why it's hyperthyroidism will come in. After that, that is a transient hypothyroidism because of thyroglobulin all washed out. So it patient enter into hypothyroid, then the recovery happening. So inflammation will subside and the euthyroid they will come again. And Graves' disease mainly due to the thyroid receptor antibodies, autoimmune disease, and hyperthyroidism. So this is the pathogenesis phase. Initially, patient presented with hyperthyroid, then enter into the hypothyroid phase, then into the euthyroid phase. So Hashimoto thyroiditis, a double-edged sword in the thyroid. Is a recent study released in the 2020 in the thyroid endocrinology. So it was a meta-analysis of observation studies. Around 39 studies were included from 2010 to 2020. In this, Hashimoto thyroiditis is a sole risk factor for thyroid carcinomas. So around 70% of increased risk of developing thyroid carcinomas in the Hashimoto thyroiditis patient. Mostly it was associated with papillary thyroid carcinomas. In the papillary thyroid spectrum, without Hashimoto disease have increased extensive diseases. But if patient having Hashimoto thyroid disease developing papillary thyroid carcinoma have a good prognosis, but it will present as a multifocal. But extrathyroidal extension, metastasis, lymph node environment or mutation wise, it was a significantly lower compared to the purely developing papillary thyroid carcinomas. And second, there's the same article, thyroid cancer associated with Hashimoto thyroiditis, similarities and difference in endemic area. It was released in the Journal of Egyptian National Cancer Institute. It also showed cancer without Hashimoto thyroiditis have a increased presentation of extrathyroidal extensions and the positive lymph nodes compared to the patients developing with the Hashimoto thyroiditis have less likely involvement of extrathyroidal extension and lymph node involvement. But you have higher incidence of multifocality compared to the patients without Hashimoto thyroiditis. And profile of a thyrotoxic patients as pyrexia of unknown origin. It is an observation case study from the Tertiary Care Center. It was released in the 2022. Here they recruited 25 patients and was followed up. In the 25 patients, initially they present as a PUO infectious. They received multiple antibiotics. Later they found out as a thyrotoxicosis. So in this, 20 patients have subacute thyroiditis and 4 have Graves' disease and 1 patient have present as a adenoma. After they followed up of 1 year, in this 40 patients of subacute thyroiditis developed transient hypothyroid state, and around of 40%, 50% were need thyroid replacement after 1 year. So back to our patient only had presented with hyperthermia and weight loss, no other thyrotoxicosis symptoms, but he was under follow-up with in view of he potentially may develop hypothyroid state. So learning panels, PUO, we need to consider as endocrine cause also, and autoimmune thyroiditis. Thank you.
How was his appetite?
Ma'am, appetite was he take normally, ma'am, but yearly satiety is there, ma'am.
Thing is for hyperthyroid stage. One thing is
Increased
increased
intake.
appetite and loss of weight. So it's diabetes and hyperthyroidism that's considered. Any other questions that you'll want? Your font should be a little bigger. I don't think it can be seen very well there. Little bigger font you must increase to. Anybody else? Any other questions? Thank you.